Yeah, good evening all. I'm sorry for the delay from my part. Uh, I'll be talking about importance of ENT surgeons in tobacco use prevention. I'm an ENT surgeon attached to Mendadkar Children's Hospital in Kurla, Mumbai. And I'm also founder trustee of a NGO, Association for Tobacco Use Hazards Awareness and Preventive Measures Association. That is the ATHAPAM, that is the recently registered NGO, and we're doing tobacco hazards awareness work in society. We're a group of 6 doctors, 3 from Mumbai and 3 from Pune, and we are doing of different specialties, and we're doing tobacco awareness work. I'd just like to briefly run through an overview of the tobacco disease burden in India and why today's topic has been put up for the discussion, so that you realize that this is such an important topic. As we all have been battling with the COVID pandemic, we've all seen that the disease was more severe in smokers, and also spitting, which is common after using smokeless tobacco, was thought to spread the disease. The COVID pandemic has again highlighted the importance of preventive strategies, and tobacco control assumes an urgency as never before. We are also in a state, India is also in a state of epidemiological transition. This means that there is a change in the disease pattern. In 1990, non-communicable diseases were about 30% of the total disease burden of our country, which has risen now to 55% in 2016. So you can understand that the non-communicable diseases are rising, and tobacco is a major preventable risk factor for all these non-communicable diseases. These NCDs include cardiac, that is cardiovascular diseases and blood vessel diseases, respiratory diseases, cancers, and diabetes. These are the major 4 groups. As ENT surgeons, we are dealing with head and neck cancers, and I'll be elaborating on it in the next slide. We need to understand that worldwide, in most of the Western countries, smoking is the predominant form of use, and hence tobacco use is considered as smoking use only. But in India, we have smokeless tobacco use, that is tobacco which is not used in burnt form, such as gutka, keni, mawa, tobacco lime quid mixture, tobacco containing betel quid, etc. Mishri in Maharashtra, which is commonly applied to tea. That is a smokeless form. This is almost nearly double the amount of smoking which is done. And we need to understand that in the Indian context, the tobacco use problem is very, very complex problem with societal repercussions also. And hence we need to understand that we need to create attention, awareness about hazards of smokeless tobacco in addition to smoking hazards. These are the figures which have been revealed in the Global Adult Tobacco Survey, the second round of which was conducted between 2015-16, and these are the figures which are the latest figures which are available. Global Adult Tobacco Survey is a systemic surveillance about adult tobacco use and the preventive measures and how effective they are. This strategy for global GATS, as it is called, is uniform all over the world, and it helps us to compare which policies have been effective, how the incidence has come down, and worldwide also we're able to compare which region or which country, which policy has been effective. And in the country also, we are able to understand which policy is helping and how the prevalence of tobacco use has come down. We need to understand a neglected topic, that is tobacco use in women. Nearly 70 billion smokeless tobacco users are there for women, and nearly 10 billion of them are working in tobacco-related occupations, being subjected to the hazards of tobacco also. Tobacco exacts a high cost on society. The economic burden of tobacco-related diseases, which was estimated for the year 2011, showed that nearly US $22.4 billion was spent on diseases caused by tobacco. The Global Adult Tobacco Survey, these are the highlights of the GATS to India 16-17 report. Sorry, I had earlier said by mistake 15-16. Tobacco use in any form is about by 28.6% adults. So you can imagine a whopping 26.7 crore people are using tobacco. It's more common in rural areas as compared to the urban counterparts. And smokeless tobacco use is the predominant form of use in our country. There is also dual tobacco use. That is, Tobacco used in both forms, smoking and smokeless tobacco, that is, both forms, about 3.2 crore people are using this. Now, as ENT surgeons, we are of the NCDs, the most we deal with are cancers which are caused by tobacco use. An alarming 34% cancers in our country are tobacco related, and these are a major health concern. Most alarming is that India has amongst the highest rates of oral cancers in the world due to tobacco use. Nearly 85,000 new cancers of oral cavity and pharynx in men and 34,000 in women are detected each year. The projections of the cancer burden by broad anatomical sites for both the sexes for 2025 have been released in the fact sheet by the Indian Council of Medical Research, National Center for Disease Informatics and Research. So we see that the anticipated rise of tobacco-related cancers is this figures which is expected for 2025. We are then discussing about the head and neck cancers in India. Why this topic is important? This is a brief background about the head and neck cancers which are common in India. The head and neck cancers in India are the commonest in men and the third common cancers in women. In Western countries, head and neck cancers are not the predominant form of cancers. We need to understand that the oral cancer is the most common form of cancer. And smokeless tobacco use is responsible for more than 90% of the tobacco related cancers. We also need to understand the regional variations as they manifest as unusual presentations of head and neck cancers in different regions of our country. Two types of tobacco use need a bit of consideration. One is Manipuri tobacco, which is a mixture of tobacco, areca nut, camphor, cloves, slake lime, cinnamon. And this is responsible for a very high incidence of oral cancers in the region where this type of tobacco is consumed. And it has been such a high incidence of oral cancer that a special cancer registry had to be formed. The second type of tobacco product which is used regionally in South India is chutta, which is reverse smoking. That is the burning end of the 5 to 9 centimeter long product is in the mouth, and as a result, palatal cancers, palatal pre-malignant conditions are more common in areas where this type of tobacco is used. Madeline Baxter has rightly mentioned in the title, "The Cancer Miracle Isn't a Cure, It's Prevention." In 1929, James Ewing, Director Cancer Research at Memorial Hospital, wrote that cancer is a public health problem of first importance, and if the public were thoroughly informed, a definite reduction in the incidence of cancer might follow. 90 years later, prevention is still not being given the attention which is needed. We'll just again overview about the types of products as we need to know what type of how we need to create awareness about it. One is smoking, as everyone knows, cigarette smoking, bidis, and the recently in the newer generation, hookah has become a craze and which is very, very harmful. We need to understand that secondhand smoke exposure can also cause diseases. This would be especially important when younger children or women come to us who may not be using tobacco. We need to ask them whether they are having secondhand smoke exposure at home, so that prevention can be addressed, preventive aspect can be addressed. Smokeless tobacco products, the other main group of tobacco products consumed in India is smokeless tobacco. The important thing is that many times in youth and women, as it can be easy to hide from other people, it is initiated for fun and it slowly becomes a habit and then it becomes a problem. So this is the surrounding people don't come to know, and this becomes a habit, and this is how the addiction starts to smokeless tobacco products. There are various forms such as tobacco chewing, gutka, betel quid with tobacco. In Maharashtra, where I come from, the missionary use, that is, many women and family households are applying tobacco to the teeth as a dentifrice. Instead of toothpaste or anything in the morning, they are using missionary, especially in rural areas, which is a form of tobacco applied to gums and teeth. The cigarette smoke has numerous carcinogens, including several tobacco-specific nitrosamines. Smokeless tobacco has also been classified as a Group 1 carcinogen by the International Agency for Research on Cancer. And as we have seen the GATS is an adult survey above 15 years age. There has been there have been other surveys for old age populations also. The longitudinal aging survey of study of India, the Wave 1 report, which was undertaken 2017-18, and the report was released recently, showed that there are any type of tobacco is being used by 30% people above the age of 45 years. So you can understand that even for the aging population, we need to understand that tobacco burden is very big. The census has shown that we have about 103 million population above 60 years, which is expected to rise to 3,159 million. And if we consider above 45 years, it's 655 million. And tobacco use, as has been shown in the Lassie report, is 30%. So you can understand how much is the use of tobacco. That is 12% smoking and 20% of smokeless tobacco use in the older population. The importance of highlighting this neglected aspect is that tobacco prevention strategies must address even the elderly population, because quitting tobacco at any age is always beneficial. We need to understand a few more things which are associated with the smokeless tobacco products. The harmful chemical in tobacco is nicotine, which is responsible for addictions, which is available in alkali and base form, free and attached form. This nicotine available to the user is increased with the presence of alkaline agents. So that means if lime is added, slake lime or chuna, katechu or kat, that which is responsible for the red color. So if this is added to the smokeless tobacco product, then the available nicotine is more, and the damage thus is much more. We need to also understand that many of the smokeless tobacco products contain an ingredient which is known as areca nut or supari. This is also a Group 1 carcinogen identified by the IARC, International Agency for Research on Cancer. Areca nut used alone also causes oral submucous fibrosis, where there is inability, difficulty in mouth opening. And this has also been known as a pre-cancerous condition, where a person can, where this condition can progress to cancer if tobacco or areca nut use is not stopped. The benefits of quitting smoking and gain in life expectancy. Benefits are immediately manifest as an improvement in the oxygen saturation, as a drop in the carbon monoxide levels, which are immediately felt. Improvement in the lung function, improvement in the respiratory pulmonary function, which is manifest within a few hours to a few weeks. But the most important thing which we can see here is the benefits of quitting and the gain in life expectancy. So the earlier a person quits, more would be the benefit. So at age 30 years, there is a 10% gain in life expectancy if the person quits tobacco in any form, which is at 6 years, at 50 years, and 3 at 60 years. Quitting at any age is beneficial. So we must extend our tobacco quit advice to all age group patients. There are numerous existing initiatives to tackle the tobacco disease burden which our government has taken. These include 85% pictorial warnings on both sides of the tobacco packaging and raised taxes on tobacco products. The SCOTPA implementation, the Section 6 of COTPA and A and B subsections ensure tobacco-free educational institutions and no sale of tobacco to children less than 18 years age. The recently amended Juvenile Justice Act 77 section, sale of tobacco to minors can lead to rigorous imprisonment up to 7 years and fine of up to 1 lakh rupees. This amendment came into effect on 15 Jan 2015. However, there is strong evidence that supporting current tobacco users to quit synergistically with other population level control measures can bring about significant changes in prevalence of tobacco use and tobacco-related disease in short to medium term. The brief spectrum for tobacco cessation includes a brief advice to stop tobacco use by healthcare professionals, more intensive behavioral support to quit, which could be undertaken individually, in groups, telephonically, or a pharmacological treatment. So the brief tobacco interventions include, this is the WHO model, and it includes 5 A's or 5 R's for motivation. So whenever a patient comes to us as ENT surgeons, we must ask about history of tobacco use, all forms of tobacco, smoking, smokeless, or any other product. We must advise them to quit tobacco. We must assess their motivation for quitting tobacco. If they are not motivated, then we need to discuss this, which I'll be detailing. If they are motivated for quitting tobacco, we need to assist them to quit. We can guide them to a helpline number or a free tobacco cessation clinic. And we need to arrange follow-up so that we know whether the person has quit, or we repeat the advice at follow-up visits. When we assess a person's motivation to quit, and if he is not motivated, we discuss the relevance, the 5 R's for motivation. We convince him of the relevance. Suppose if it's a parent, then we can tell them that if there's a child at home, that the child may get a second-hand smoke exposure, and so he must quit. If it's an elderly person, we must tell them that they can be at a high risk for non-communicable diseases, and they must quit. We need to tell them, if they've come to us for any health-related condition, we can give a contextual references about the risk. If they come with leukoplakia, we can tell them that this may progress to a malignant lesion in case they don't quit, and the risk involved, which can motivate them to quit. And we tell them the rewards, that in the present condition, what can be the factors which can help them. So if they quit early, they get a gain in life expectancy, then health improves, and the disease may not progress to malignancy if they have come with a pre-malignant lesion. We understand what are their roadblocks, what are the difficulties which they are facing, and we try to help them out. In case the person is still not motivated, we repeat this again at the next setting when he comes to see us. There is evidence, there is proved evidence that the brief cessation advised by healthcare professionals can increase tobacco abstinence by 70% at 6 months or longer. The advantages are, it takes a very short time, it's feasible, it's effective, and it's efficient. So what can we do? Now coming to the main point of today's topic, what can we do as ENT surgeons? We can advise all our patients to avoid and discontinue all forms of tobacco use. We can increase awareness about the harm caused by tobacco. This is mentioned, there is a tobacco-free initiative. Every year, the World Health Organization draws attention to the tobacco burden by declaring May 31st as a World No Tobacco Day. Each year, a theme is declared, and on a specific topic, awareness is created worldwide to draw attention to the myriad aspects of tobacco control. For the year 2000, in one of the years, the role of health professionals in tobacco control was also the theme for the World No Tobacco Day. This monograph has mentioned the World No Tobacco Free, the WHO Tobacco Free Initiative monograph mentions the various aspects about role of healthcare professionals in tobacco control. So what can we do? The brief advice is, we all are busy, you may all be attached to institutes, may not get time, but you can always ask if there is history of tobacco use. If yes, you must advise to quit the tobacco. And if they're quitting tobacco, we can refer them to the free tobacco cessation clinics list on the National Tobacco Control Program of our Government of India's website. But the National Tobacco Control Program is run at the central level, at the state level, and the district level. So the district level, many of the district level hospitals have free tobacco cessation clinics, and the list of these nearby clinics is available on the Tobacco Control Program website. Also, many of the medical colleges, government dental colleges, government medical colleges, and other institutions are having facilities for tobacco cessation in the psychiatry department or in the preventive oral health departments. These nearby hospitals can also, the patient can also be referred to these nearby centers. The Government of India also has launched a tobacco-free hotline. It's a toll-free number. The person doesn't have to pay for it when the call is made to it. It is 1800112356. When a person using any form of tobacco makes a call to this number, they get information in the counseling advice about quitting tobacco. And with modern post-pandemic, almost all patients, many of the digital technology is permitted, and a lot of people are having smartphones. So, missed call given on this number 011 22 901 701 can lead to the tobacco user will receive a text message where he will get advice for quitting tobacco. Both these services are free. As ENT surgeons, another thing which we can do is oral cavity examination. So all patients who are coming to us, we can do the different parts of the oral cavity. We need to see regarding where the if a tobacco user patient comes, where the tobacco has been kept. We need to see that. I'd like to just point out a few differences about the head and neck cancers which are seen in the Western countries and the type of cancers which are seen in India. We have predominantly form of tobacco use is smokeless tobacco use, and many times the tobacco lime mixture is kept in the gingival buccal sulcus. So many times because of the chewing tobacco, mouth cancers, alveolar region, buccal mucosa, retromolar trigone region cancers are commonly seen. The gingival buccal cancers are also seen. Because of the smokeless tobacco, the saliva is kept in the mouth, many times held in the mouth. Hypopharyngeal cancers are more common in India compared to laryngeal cancers. Also, post-cricoid cancers, which are rare globally, are not so rare in India. Nasopharyngeal cancers are rare in India, however, they are seen in the northeast region. And as I had mentioned earlier, regional variations we need to keep in mind, such as where reverse smoking is there, we need to look out for palatal cancers and palatal pre-malignant lesions. As we all know, these are the various regions of the mouth which need to be examined. The lip mucosa, the lip, the gingiva buccal region, the vestibule, the tongue, the floor of the mouth, the soft palate, the hard palate. As we all know, that the pre-malignant lesions could be leukoplakia, erythroplakia, melanoplakia, oral submucous fibrosis. So we need to be aware of this. In addition to treating them, at the same time, we need to advise the patient that they have to quit the habit. Only writing on paper, stop using tobacco may not suffice. The above numbers which we have given, we need to share them with the patient so that immediately the patient can get some help quitting the tobacco disease. So tobacco, what is the rationale for role of ENT surgeons in tobacco control? Why have I been invited to talk to you by Nilima Madam today? It's because tobacco use is a common risk factor between oral disease, head and neck cancers, and major chronic non-communicable diseases. So there's a rationale for ENT surgeons to support tobacco control. Article 14 of the WHO Framework Convention on Tobacco Control says that the first step of comprehensive treatment can be integrating brief tobacco interventions into existing healthcare system. This should be available at all levels of service delivery, though mainly focused on primary care settings. It means that at whatever level you are practicing as a student, or later on when you go into practice as an individual private practitioner, or as an institutional attachment or a charitable hospital, wherever you are working, whatever type of patients you see, you must integrate tobacco control. I'd just like to share a very small recent experience which I had about 2 weeks ago. A 73-year-old person had come to me with deafness. He was a cardiac patient, and he had been having long-standing hypertension. On asking, he gave history of tobacco use. Once he said tobacco use, after seeing the year, the first thing I did was I asked him where he used to keep the tobacco, and he said the gingival buccal sulcus. So immediately I first examined the oral cavity, and I saw to my surprise that there was a leukoplakia patch. So we had to refer him for excision because there was a surrounding erythroplakic patch also. So totally asymptomatic patient, just though he had comfort deafness, a oral cavity examination, in addition to quitting advice, we are able to detect a lesion, a pre-malignant lesion early, and we can help progression of the disease further. So we need to integrate tobacco awareness. We need to ask history of tobacco disease. The patient may come to us for ear complaint, nose complaint, but please ask history of tobacco and please do the oral cavity examination also. And most importantly, what we can do as ENT surgeons is we can show the actual effects of sedation. I have another experience about 2 years ago where a engineer patient had a leukoplakic lesion. He's a chronic smoker. After showing him, I told him that you go do self-examination at home, see in the mirror, you will see this white lesion. You stopped using tobacco. Later, he came again for other year complaint. He had come to me for otitis media, and that time he said I used to see I stopped smoking, and I used to examine my mouth every week in the mirror at home by using a torch, and I saw that it is regressed. And 1 year later when he came, it was almost nearly regressed. So once you explain to the patient, you can show them the actual effects of sedation. You ask them to do local examination. It shows if we are able to help patients at an early stage and prevent further progression of the disease. And reduction of oral lesions. So once we show patients the actual effects of sedation, reduction of oral lesions due to tobacco use, such as lesions at the site where tobacco is kept in the gingival sulcus. We can help to, once we tell them to quit, and we can help them to sustain the quit attempts by showing them that this lesion has regressed or this lesion has disappeared. So these are the roles of an ENT surgeon in individual capacity, that we ask history of tobacco use, specifically smokeless tobacco use. And as you all are from different parts of the country, you need to know the regional, commonly used regional products that we need to ask. In Maharashtra, we ask about mishri use, which type of tobacco you're using, and whether the person is consuming it. At the organization level, as our association, as our Indian Medical Association, as our National ENT Association, a local branch, state level, national level, international level, we can participate in creating awareness in the community about tobacco hazards. We can organize, the WHO has World No Tobacco Day, and numerous activities are there. World Cancer Day, there are numerous activities. We can create awareness about tobacco being a preventable cause of cancer. Since 2015, I've been creating awareness about tobacco cancers being preventable by conducting programs for school students that a tobacco habit must be quit, and for sensitizing various government department officials such as education, oral health department, public health department, that tobacco related cancers are preventable and we need to stop tobacco use. So such initiatives we can take at an individual level, our association level, across as an ENT expert. Other organizations can also invite you to create awareness about tobacco hazards. Another important day is May 31st every year, where you can create awareness in the surrounding areas, in your local educational institutions, colleges, uh, whichever platform is where you are a member, a gymkhana or a sports arena where you are a member, you can create awareness that tobacco is harmful. World No Tobacco provides such an opportunity, which is May 31st every year. Then the research. All of you present papers at conferences, present documents. So research tobacco related, you can at your area or in your region, what are the tobacco related cancers? Which are the types of cancers of the head and neck which are seen, and which are the correlation with tobacco products which are used? And the effect of treatment, early diagnosis, screening effects, all these can be undertaken. And as Madam has invited me to talk to you, training curricula need to to incorporate tobacco awareness for prevention. And many of you are aware that some of your colleagues may also be using tobacco. The medical students could be using tobacco. So they may have started this habit before coming to the medical education system. So we can all help them to quit the tobacco habit as peers, as friends. We can help them all to quit. So this is another way that you can help your your friends to quit the habit. As an ENT surgeon, since 2014 till date, till today, today morning also we have done a program. We've been doing school-based tobacco hazards awareness program in Mumbai. As adolescents is the most susceptible age group to tobacco, till the pandemic we had done about 15,000. And in view of the recently post-pandemic, the schools have reopened. From July 29th, we started our program again. And we have done this program from July 29th till date. We did about 7,500 students. We thought we would do our contribution for Azadi Ka Amrit Mahotsav by starting this program again in this year. So adolescent boys and girls, we give information about tobacco hazards, we give information about quit lines, and we give them a no tobacco pledge that they should be proud to be tobacco free. And we tell them about refusal skills, that they must not even experiment even once, how much ever anyone insists. So with this program, we have published the initial results in medical journals, and we are undertaking further studies also. So such initiatives will help to prevent initiation of tobacco use. Right, up till now we had seen our role as ENT surgeons, how we will diagnose early, how we will advise our patients. But we are doing primary prevention, that is preventing addiction, preventing experimenting of tobacco use by adolescents, as they are the most susceptible age group to tobacco initiation. So to conclude, as ENT surgeons, you need to ask history of tobacco use, smoking and smokeless products. Please ask during each visit, starting from today if you're going back to OPD, with vital signs. Just as we document pulse, blood pressure on the paper, please document tobacco use during each visit. If your patient is using any form of tobacco, you must advise them to quit the habit. The quit line numbers, which I have shared with you, if you want, I can share them again with madam and ask you to take it from her. The quit line numbers, the M cessation initiative, that is where the SMS is to be given on 011 22. The SMS number which I had shared, 22901701 number, or a reference to tobacco cessation clinics. We need to display this quit line numbers, that is 1800112356, and the M cessation number 011 22901701. We need to display these numbers in waiting area so that the patient, the relatives, or whoever is coming with the patient can avail of benefit of these facilities. And if patient is using any tobacco or SLD products, please do an oral examination, even if he comes for any other ENT symptoms. We need to consider inclusion of tobacco hazards awareness information in teaching curriculum. Each one of you can make a difference and help to sway the public opinion towards proud to be tobacco free. Thank you.
Thank you. Thank you, Dr. Ghate.
Yeah.
Good evening to everyone. I must congratulate you, Dr. Ghate, that you are doing such a great job in
Thank you.
promoting the tobacco awareness and
thank you, madam. Thank you. Thank you for giving me this opportunity.
5,000 adolescents, and that's a really great job. And we always keep on talking about treatment, and as the age-old adage says, prevention is better than cure.
Yeah.
So if we can catch the diagnosis early, then
Yes.
we can really help these patients.
Yes.
We feel depressed that patients are coming at such an advanced stage to us, and the oral cancers, they are causing so much morbidity to the patient. So if we can help even a couple of individuals who have started this tobacco use, and we can sway them towards tobacco free,
Yes, ma'am.
proud to be tobacco free, and definitely we will be doing our job.
Yes,
and as you said, this should be the part of a routine examination
yes,
and history. And if you can advise them at that point, They may or
Yes.
may not take price, but
Yeah.
definitely they will have it at the back of their mind that
Yes.
this is something which is harmful to
Yes.
my health. So
Yes.
maybe
Yeah.
over some days, months, they do think that
Yeah.
if they stop it, they will be helped.
Yes. Yes.
So, so thank you so much for the
Thank you,
talk.
ma'am.
And if there are
Thank
any
you, ma'am.
questions, can you see the chat box
Uh, to see you.
on the right hand side?
Yeah.
Uh, are there any questions in the
No,
chat
no, no
box?
messages, madam. No messages. Yeah, I got one from Neeta. Ma'am, during oral examination, I used to see not white patches, but a linear white line in buccal mucosa as in adjacent to the area where the upper and lower tooth meet. Are these lesions pre-malignant? Hello, can you hear me?
Yes, we can.
Yeah. It could be you need to know whether the person is using tobacco. Sometimes it could be a bit of like lichen planus also. You can take a dermatologist's opinion for these oral lesions also to see whether there are any associated skin lesions also to the person. This technical question I wouldn't know. Where can I find a PPT in NB site under which question? Under which section? I think the NB department organizers will be host will be able to tell you.
Mr. Navneet, where can they find the presentations?
On our website, ma'am.
Okay.
No, so is it under some CME or what is the heading of the
Yeah,
section?
website.
Webinars.
Webinars. Okay.
Yes.
Okay.
They can log in through their registered email IDs. So, dear trainees, you can ask the relevant questions.
Any more
So
questions are there? I'll be very happy to answer.
mainly it has been a thought-provoking
Thank
talk.
you, ma'am. Thank you very
Uh,
much, ma'am.
Thank you, Dr. Neeta, because sometimes the doctors, the ENT doctors, they are too focused on the presenting complaint, but
Yes, madam. It happens. It happens.
news related to so many oral complaints as well as smoking is related to so many nasal complaints and also with ear diseases. It has been linked to ear
Yes.
diseases. So,
With children
last,
and second-hand
yeah,
smoke exposure at home.
yes. And even at early age, the people have started using this. And the hookah use, as you said, hookah
Yes,
use
madam.
is also prevalent in Delhi, and the government keeps on swaying here and there about banning the hookahs, and then they allow it again in the restaurants. And so, even if it is a smoke-free or it is a flavored hookah or something, it is contributing to the pollution and contributing to the harmful effects of inhalation of those.
I'd like to just add about hookah. We started our school programs. Almost each school children are asking about hookahs. So I'd just like to clarify a few points which we tell the students also. To make the tobacco harshness less, additives are added, flavorings are added. So more tobacco is consumed. And the session lasts longer. A hookah session lasts about 10 to 30 minutes. So the more tobacco is inhaled and more second-hand smoke exposure also occurs to the person, though he is not using hookah, who's with the person using hookah. And thirdly, many times mouthpieces are shared. So infections like, as we know, respiratory infections like tuberculosis can also be shared. So hookah is bad and it's not to be used. No tobacco is fashion. It's not to be used, and we need to be very uh, vocally aggressive that it's not to be used under any circumstances.
Yes, exactly.
I mean, very scientifically, we are telling how much it's much more harmful than any other, because less flavor, because of the flarings, less irritation. So more smoke gets inhaled inside, and the damage occurs much more nicotine, more all harmful chemicals going inside.
Yeah. I think there are one or two more questions.
Yeah, 1 minute, madam. One question I have to answer. Just 1 second.
Yeah. They keep on popping on my screen, but somehow I'm not able to retrace them.
It's the someone has asked me about is vaping related to oral cavity cancers? Anyway, vaping, yes, not to use all the e-cigarettes. Everything is banned and it's not to be used. Is vaping anyway related to oral cavity cancers? It's not to be used. Varicose lesion is malignant or pre-malignant. It depends. It needs to be examined and whether the person is using tobacco. Then someone has asked me, madam, what is KOTPA? So it is the Cigarette and Other Products, Other Tobacco Products Act 2003. Which prohibits the advertisement of and related to I'll just read it out. The Cigarette and Other Tobacco Products Act 2003, or KOTPA 2003, is an act of parliament enacted in 2003 to prohibit advertisement of and to provide for regulation of trade and commerce in production, supply, distribution of cigarette and other products in India. So it is regulation for sale of tobacco products in India, and it has various sections. So 6A, 6B section ensure no sale to minors and no sale near education institutions. Any more difficulties? Any more questions?
No, I don't think there are.
Yeah, I think, ma'am, I've replied to all except the website where I can find this PPT. That is, I think.
Mr. Navneet has told them, and if they search it, they'll be able to find it.
Yeah.
So
And I've shared my email ID also in case anyone wants any more information about tobacco awareness. I'll be very, very happy to share it. It's there on the last slide, ghate1010@gmail.com.
great job.
Thank you.
Yeah.
Thank you very much, madam, and thank you, friends, for listening to this. And thank you, ma'am, for giving me this opportunity to present my humble efforts on the national level. Thank you very much.
Thank you so much, Dr. Neeta.
Bye, ma'am.